So, good afternoon, everyone, and welcome in the clinical combined rounds of Department of Medicine Unit 3. We are going to present very interesting case today. Uh, we have given the very interesting title, Unmasking the Unusual, Navigating the Novelty in a Common Case. So, Dr. Sankeet is going to discuss, and then Dr. Megha will give. Thank you.
Thank you, sir. So I am Dr. Sankeet. I'll be presenting the clinical combined rounds on behalf of the Department of Medicine Unit 3, along with Megha ma'am, titled Unmasking the Unusual, Navigating Novelty in a Common Case. At the outset, I'd like to extend my heartfelt gratitude to our head of unit, Professor Sanjeev Sinha, sir, for his constant guidance and mentorship. I'd also like to extend my gratitude to our other faculty members. So for the case presentation, prior to the presentation at AIIMS, we have a 21-year-old male, shopkeeper by occupation, who presented with swellings in his left elbow and base of left middle finger for the past 1.5 years. He did not have any significant symptoms of weight loss, loss of appetite, fever. He did not have any history of trauma, cough, hemoptysis, pet exposure, or recent travel. His past history was also non-contributory. Prior to presentation at AIIMS, he had presented at multiple centers and was prescribed the following antibiotics, which included vancomycin, piperacillin tazobactam, and even oral levofloxacin for a duration of 2 months, metronidazole, meropenem, cotrimoxazole, ceftriaxone, and ciprofloxacin. However, despite these antibiotics, he did not experience any symptom resolution. Prior to presentation, he was investigated on multiple fronts for the possibility of bacterial infection, fungal infection, and TB in the form of cultures, AFB midget on multiple occasions, which were found to be negative. His laboratory investigations prior to presentation revealed a normal LFT-KFT, a normal CBC, an elevated ESR of 40 mm per hour. His HIV serology was negative, and a chest X-ray and CACT chest done at an outside setup revealed no evidence of any pulmonary parenchymal abnormalities. Prior to presentation, he had been investigated with an MRI of the hand, which had revealed an evidence of a soft tissue collection localized to the extensor aspect of the elbow as well as the extensor aspect of the middle finger. However, this MRI did not reveal any evidence of bone erosions nor any evidence of joint involvement. On presentation to AIIMS, these were his lesions. Characterizing them further, the elbow swelling measured 4 into 5 centimeter. It was fluctuant with no overlying skin changes. It was fixed to the underlying structures, but importantly so, it did not show any evidence of inflammation in the form of tenderness, warmth, or redness. Similar findings were noted in his left hand. It was a fluctuant swelling fixed to the underlying structures and also did not show any evidence of inflammation. Characterizing these findings, he presented with 2 cold abscesses on his left hand and left hand. Putting it together, we have a young man, apparently immunocompetent, with an appendicular predominant left hand involving cold abscess, with no apparent clinical evidence of dissemination, not responding to antibiotics, and being investigated on multiple fronts with AFB and midget proven to be negative. So putting together the differentials for this case, we initially kept the following differentials, which included NTM. Given his milder and protracted symptom course, along with multiple sites of involvement and lytic predominant involvement, we favored the diagnosis of NTM. However, his AFB was negative on multiple fronts, and this being a rarer presentation were points against the same. TB could also present with similar findings. However, the finding of midget negative on 2 occasions puts it lower down the line and brings to the fore the importance of considering alternative bacterial etiologies. These include brucellosis. Brucellosis could present with articular predominant involvement, which is noted in around 27 to 30% of cases. The absence of pulmonary parenchymal involvement in our case further supports the diagnosis. However, the absence of animal contact and the seemingly immunocompetent nature of our patient put it less down the line. Further, when brucellosis does happen to involve the articular skeleton, it is predominantly axial. Given the appendicular predominant involvement with lytic lesions and an ill-demarcated collection, we can entertain a diagnosis of actinomycetoma as well. However, since he did not have any significant history of trauma and the fact that it involved his left hand, which was his non-dominant hand, the absence of sinus tract or granules, and the absence of a firm collection put it lower down the line. Now, among nocardia and actinomyces, nocardia is known to have lesser sinus tracts and lesser granules. So among the two, nocardia would be more favored. A eumycetoma may also be considered for similar reasons. However, on account of, again, an absence of trauma and non-dominant predominant involvement, Absence of sinus tracts and granules, it is lower down. Histoplasma could present with appendicular involvement. However, in order to present with an appendicular involvement in an immunocompetent individual, it would require trauma with a significant loading inoculum of the organism, which was absent in our case. Further, in immunosuppressed individuals, it often involves the axial skeleton, again a pointer against the diagnosis. Sporotrichosis may be considered, given that we had concurrent left hand and left elbow involvement in a seemingly lymphatic spread with the absence of pulmonary and systemic features. It is points favoring this diagnosis. However, sporotrichosis without involvement of the superficial dermis or an extracutaneous form of the same is a rather rare presentation. Further, his trauma history and occupational history were non-contributory. Finally, in order to entertain a diagnosis of opportunistic mycosis like Candida, aspergillosis, and cryptococcosis, it is essential to evoke an immunosuppressed state. Again, in this immunosuppressant state, it often involves the axial skeleton more so than the appendicular. Finally, for our approach to this cold abscess, we initially kept top differentials of fungal etiologies like histoplasma, sporotrichosis, bacterial etiologies like non-pyogenic organisms of actinomycosis, nocardia, brucellosis, and finally NTM and tubercular etiologies. In order to characterize the same, and given the atypicality of our presentation and the absence of AFB and midget, we went ahead with an MRI to characterize the lesion, and to characterize the evidence of dissemination, we went ahead with the PET scan. To discuss the same, I would like to call upon my radio colleagues and nuclear medicine.
Good afternoon, everyone. I'm Dr. Lukesh from Radiology. So the chest X-ray was presented to us during that time, and the chest X-ray showed there is a blunting of the left CT angle with a meniscus sign suggestive of left pleural effusion, and there was some reduction in the volume of the left lung. The elbow X-ray suggested there was a large soft tissue around the elbow joint with associated some periosteal reaction as well as some cortical irregularity over the lower end of humerus. Hand X-ray revealed there was erosion of the third metacarpal head, and there was a large soft tissue around it, which had some foci of tiny calcifications within it. So it also suggests that there is some joint involvement with associated underlying bony erosion. So suggestive and infective etiology. Then MRI was done, and it shows there was a empyema. There was loculated pleural effusion in the left lung, and there was some necrotic nodes in the axilla as well. And the large soft tissue around the elbow joint showed this T2 hyperintense synovial effusion with some synovial proliferation. This T2 hypointense band-like thing shows synovial proliferation. Also, the medullary cavity shows T2 hyperintensity suggestive of intramedullary involvement, and there was some erosion of the bone in the medial aspect. So this is the T2 weighted image and T1 weighted image. T1, we can see the erosion better in the medial aspect. This T1 hyperintensity of the cortex is lost. Also, there's diffuse synovial proliferation, and there is subcutaneous edema as well around the elbow joint. And on post contrast images, it shows thick peripheral enhancement of the suggestive of an abscess, evolving abscess in the joint space. So this is the abscess, and this is the soft tissue proliferation in the joint. This is the hand MRI, which shows this is a T1 weighted image. There's the third metacarpal head shows erosions and medullary cavity involvement, and there is large soft tissue around it, which one post CAT shows peripheral enhancement, suggestive of an abscess formation. So I'd like to call upon my nuclear medicine colleague.
Good afternoon, everyone. I am Dr. Nivedita, Senior Resident Department of Nuclear Medicine, and I will be reviewing the findings of F18 FTG PET-CT for this patient. So the patient underwent a baseline F18 FTG PET-CT on 1st June 2023. The image on the left is a maximum intensity projection or a MIP image showing physiological tracer distribution in the brain, myocardium, and urinary excretion. Also noted as multiple foci of increased tracer uptake in the neck, thorax, abdomen, and axial and appendicular skeleton. On the right, we have fused PET and CT, transaxial PET and CT images showing the image is not clear, actually, maybe because of contrast. So we can see bilateral enlarged discrete supraclavicular lymph nodes. In the second image, we are seeing a left-sided nodular pleural thickening. Also noted are left-sided axillary level 1 lymph nodes, subcarinal and hilar lymph nodes. In the third image, we are seeing subcapsular hepatic deposits. Fourth image on the top, we are seeing right-sided lytic lesion in the right seventh rib. And in the second, in this image, we are seeing a lytic lesion in the spinous process of D2 vertebra. And here we are seeing a bilateral enlarged discrete inguinal lymph node. In the second slide, we are seeing the disseminated skeletal involvement. Here we are seeing lytic lesions in the proximal left radius and ulna with contiguous involvement of the surrounding soft tissue. We are seeing a large lytic lesion in the body of sternum. We are also seeing lytic lesions in the distal ends of bilateral femora, left third metacarpal with contiguous involvement of the surrounding soft tissue, right calcaneum, and the right proximal tibia. These scan findings are consistent with disseminated tuberculous involvement.
Given the prior entertainment of atypical bacterial infections and NTM, a modified AFP stain was sent for the same patient, which was found to be negative. Now, given the accessibility of his left elbow swelling, this swelling was aspirated and a Gene Expert Ultra was sent. The Gene Expert Ultra detected MTB and also detected rifampicin resistance. Given the microbiological diagnosis and the evidence of radiological dissemination, it was all the more imperative to go ahead with the immunodeficiency workup for the same patient. The immunodeficiency workup revealed a normal T cell and NK cell functional assay. Mendelian susceptibility to mycobacterial disease workup, which was sent by flow cytometry, was negative. The individual had normal immunoglobulin levels. We wish to investigate the MSMD workup further with the next-gen sequencing, but the patient could not have the same. For his MDR-TB, he was initiated on a bedaquiline-based all-oral multi-drug resistant TB regimen. The patient, on follow-up, had the following findings. This was his baseline swelling, and following 18 months, we can see that there is complete clinical resolution of his left hand swelling, and the same could be said with his left elbow swelling with no residual deficits. In order to discuss these radiological features of resolution, I'd like to call forth my radio colleagues.
So following intermittent, the interval chest X-ray was done, which was reduced effusion, but still the effusion was present in that June scan. And also on the hand X-ray, there is significant resolution of the soft tissue swelling, but there is and still presence of sclerosis at the metacarpal head. So suggestive of a response to therapy. Also, this is the MRI image, which shows residual T2 hyperenhancement, T1 hypo. There is some residual erosion, but this all points to there is no medullary cavity involvement, no hyperintensity in the medullary cavity. So this all points to a sequelae of the infection, not an active disease as such. And minimal effusion, minimal post-contrast enhancement of the synonym was seen, which is post-infective sequelae. So suggestive of radiologically also it's a resolved disease.
Now I'll be showing the response assessment scan of the same patient. So on the left, we see the baseline MIP image, and on the right side, we see the post-treatment MIP images. The patient received ATT for 18 months, following which he underwent a response assessment scan on 14 November 2024. So here we can see that there is resolution of bilateral cervical lymph nodes. Also noted is the resolution of the lytic lesion in the spinous process of D2. There is resolution of the mediastinal lymph node, of the left-sided nodular pleural thickening, as well as the left-sided axillary lymph nodes. There is also resolution of the subcapsular hepatic deposits. Here, we are also seeing the complete resolution of the soft tissue involvement around the left proximal radius and ulna. There is also healing of the lytic lesion with sclerosis. Here also we can see that in the left third metacarpal, there is complete resolution of the soft tissue involvement surrounding the bone, as well as healing with sclerosis. All these findings are suggestive of a near complete metabolic response. 2 points to note here are that we can also see that there is diffuse increased tracer uptake in bilateral forearms, likely due to patient positioning during an MRI earlier in the same day. And another advantage of this modality is that since it's a whole body imaging modality, it is excellent for a treatment response evaluation and for evaluating the disease extent in a single study from head to toe. Now, having discussed the case presentation, let's move on towards the discussion. We'll be discussing what was unique in this case, the rarity of this presentation, the diagnosis and differentiation of different types of cold abscesses, immunology and tuberculosis, and the various treatment considerations. When we discuss how common is primary MDR tuberculosis, globally, we have the Global Tuberculosis Report in 2023, which suggests that 3.3% of MDR RRTB cases are primary, compared to 17% which are previously treated. The graphs also show a declining trend not only in primary MDR-TB but also in previously treated MDR-TB cases across the previous decades. When we compare this to the Indian report of the first National Anti-Tuberculosis Drug Resistance Survey conducted, we note that we have annual 26 to 27 lakh TB cases, of which 24 lakh are not notified. Among these, 2.84% are primary MDR compared to 11% which are previously treated cases. Our patient, in his initial presentation, had soft tissue abscesses in the extremities, specifically the left elbow and the left hand, which later penetrate to involve the bone and the joint and then the disseminated involvement. So how common are these soft tissue abscesses? Soft tissue abscesses themselves represent 1 to 1.5% of all extrapulmonary tuberculosis cases. Among these, the most common locations are the thoracic and abdominal wall, comprising 1/3 of all of these cases, followed by paravertebral spaces. In contrast, tuberculosis abscesses in the limbs, as we saw in our case, are extremely rare, with only 5 reported cases in the PubMed database from 2000 to 2019. When we review this literature of these 5 cases, with the subcutaneous collection involvement in the thighs, the forearm, the hip, it is important to note that all of these 5 cases were rifampicin sensitive, compared to our case, which was a primary multi-drug resistant tuberculosis. Also, 4 out of these 5 cases either had a miliary or a pulmonary parenchymal involvement, and 50% of these cases may not present with the constitutional symptoms of tuberculosis. The persistent AFB and midget negativity, which led to delay in the diagnosis, made it imperative for us to consider other differentials for cold abscesses, which include atypical bacteria such as brucellosis, which commonly involve the axial skeleton. These abscesses commonly have contrast enhancement without necrosis in comparison to tuberculosis. Nocardia and actinomycosis, where nocardia presents with abscesses with irregular rim enhancement, often with satellite lesions, and bone involvement here is rare in comparison to tuberculosis, which commonly infects and involves the surrounding bone structures. Actinomycosis, which clinically presents mainly in the jaw, cervical areas, or in trauma-prone areas, with presence of sulfur granules visibly in the drainage, and also sinus tracts and abscesses that can be seen on radiological investigations. Radiology may not be a very specific modality to differentiate tuberculosis from other non-tubercular mycobacterial diseases and fungal infections such as histoplasmosis. So then we come to the diagnosis through microbiology, which led to our confirmation. Inherently, musculoskeletal and osteoarticular tuberculosis are themselves paucibacillary diseases, where sensitivity of culture is relatively low. As in our case, these are frequently misdiagnosed as pyogenic, and these patients are often subjected to multiple courses of antibiotics. These common antibiotics being levofloxacin, linezolid, which in fact are second-line ATT. This not only decreases the sensitivity of AFB smear positivity, but also further delays and leads to therapeutic and diagnostic dilemma in such cases. We have various microbiological investigations with different limit of detections. Although compared to microscopy, expert and expert ultra nucleic acid amplification tests have a limit of detection of 112 and 15 colony forming units per ml with a low turnaround time. These help us in early diagnosis. The liquid culture system with similar limit of detection has a very prolonged turnaround time, which may extend to up to 3 weeks. When we compared to various other samples, we note that expert ultra has higher sensitivity compared to expert trip, except in lymph node aspirate samples. And as seen in our case in pus aspirate, the sensitivity of expert ultra is 90% compared to expert RIF. This study, published in Journal of Infection in 2022, took into account 186 osteoarticular TB patients. Here, the gold standard for comparison was a composite reference standard comprising clinical,
laboratory, histopathological, radiological, and a 6-month follow-up data. Here it is important to note that the sensitivity of culture in diagnosing these postbacillary tuberculosis samples was less than 40%, and expert ultra had an incremental benefit of 12% over expert, which was statistically significant. Also, in additional studies, it has been shown that joint fluid aspirates can lead to higher sensitivities as up to 27% compared to expert RIF. Coming to our second objective, or causality of delayed tuberculosis diagnosis because of increasing consumption of antibiotics, which are commonly second-line ATT, we come to this study, which is an analysis of data of National Antimicrobial Consumption Network, that is NACNet site, conducted over North India over the past 7 years from 2017 to 23. Here we can see, as compared to 2017, the defined daily dosage per 1,000 patient bed days among fluoroquinolones, aminoglycosides, and linezolid, which are all second-line ATTs, has increased 5 to 7 times from their values in 2017. This brings us to the fact that rampant use of these second-line ATT drugs, whether be it for pyogenic abscesses, can contribute to our two unique features. First, the AFB and persistent midget negativity, and secondly, the apparent primary drug resistance in this case. It also tells us to emphasize on proper history taking and meticulous antibiotic history taking in case of chronic abscesses. Among the MDR-RR TB isolates, it's also important to note that 15 to 16% of them may be fluoroquinolone resistant, and hence importance of fluoroquinolone resistance testing before initiating treatment is of importance for better treatment outcomes. Now, when we talk about immunity and tuberculosis, as in our young patient who first started with tuberculosis of soft tissue abscesses in atypical locations and further led to dissemination, it is important to rule out alternative causes of immunodeficiency, such as HIV, diabetes, corticosteroid use, and chronic diseases, and then perform directed testing. It is also important to note that granulomatous disorders such as tuberculosis are mainly mediated through cell-mediated immunity involving interferon gamma, IL-12, and tumor necrosis factor as the main driving mechanism. Criteria which decide this are the DST inclusion criteria, where if there is isoniazid resistance in both INH-A and CAT-G, extensive pulmonary tuberculosis disease in the form of bilateral cavitatory or extensive parenchymal damage, presence of extensive extrapulmonary TB such as miliary TB, TB meningitis or CNS TB. In all such cases, longer regime is preferred over shorter regime. PLHIV in itself, without severe PTB or EPTB disease, does not warrant a longer MDR-RR-TB regime. So in our patient, according to PMDT 2021, we started him on a 18 to 20 months regime of betaquilin, levoflox, linezolid, chlorphazamine, and cycloserine. And as we have seen the clinical and radiological response and monitoring through the PET scan, we have now stopped ATT with full resolution. It is important here to note that in case the patient develops toxicity due to any of these drugs, this is the replacement sequence that is to be followed given by PMDT. A paradigm shift has been brought about in the management of MDR-RR-TB with the BPALM regime, with landmark trials of TB practical study telling about a cure rate of 89% versus standard of cure, and the NICS-TB trial showing its favorable outcome and time to culture negativity. The BPALM regime can be given for pre-XDR and MDR-TB patients. It should be noted that EPTB, such as ours, which was disseminated in osteoarticular, in such cases, still all oral longer regime is to be preferred. This is still not recommended in pregnancy breastfeeding in less than 14 years owing to the limited evidence. And if the patient has, in the initiation of fluoroquinolone resistance, the duration is increased to 9 months and the regime changed to BPAL rather than the BPALM regime. So through this case and from our patient, we've learned that chronic multi-drug resistant tubercular cold abscesses in extremities is a rare presentation. Rampant use of fluoroquinolones and other second-line ATTs impose a diagnostic and therapeutic dilemma in diagnosing these patients. High risk of tubercular osteomyelitis exists with these soft tissue abscesses. Gene Expert Ultra has much better sensitivity in diagnosing postbacillary musculoskeletal and osteoarticular tuberculosis. Meticulous drug history is important in tailoring treatment regime and achieving good favorable outcome. And BPALM regime may bring a paradigm shift in management of such cases. I would like to extend my gratitude to the Department of Radiology, Nuclear Medicine, Microbiology, Transplant Immunology, and Immunogenetics, and our nursing and healthcare staff of our medicine ward for the patient care that they offered. And last but not the least, I would like to come to a conclusion that medical decisions ultimately should balance the Occam's razor's simplicity and the Hickham's dictum's acknowledgement of multiple conditions. With this, we come to the end of the clinical combined rounds. And I would like to now call upon Professor Piyush Ranjan for his work. Thank you.
Thank you very much, Dr. Megha, Dr. Sangeet, and the whole team for bringing this this case report to all. So we would say that what's so special about the case? There was a cold abscess. We put the needle. We got gene expert done. Diagnosis was there. The patient was treated. What's so special in sharing this particular case? So with this, I would like to stress upon the fact that even if it was as simple as that, it took almost 18 months with the other teaching hospitals and the other doctors, qualified doctors, to diagnose it. And even in our institution, we could get the diagnosis in the second or third week only. So the learning point is that the cold abscess, when there is atypical presentation, so tuberculosis is much lower in our differential diagnosis list, number one. And number two, when the other diagnostic modality like MGIT culture and AFB, they are negative, so we tend to think about the other differential diagnosis which we got in this particular case. Number two, it is very important to look at the injudicious use of antibiotic, as a second line antibiotic was being used. So this case, because of multiple exposure of fluoroquinolones as well as linezolid, the patient probably got drug-resistant tuberculosis during the course of illness, because primary MDR, as we have seen, is much lesser in their prevalence, 2 to 3%. And so when we look at the last but not the least is the success story. Extrapulmonary tuberculosis, even if it is drug sensitive, is very difficult to treat. We could cure the case of extrapulmonary tuberculosis with bone involvement osteomyelitis which was multi-drug resistant successfully within the 18 months. The credit goes to the good immunity of the patient also, but from the perspective of treating team, we could very well perceive that this patient deserves is a longer duration of the MDR regime. That's why the patient got successfully treated. So for closing remark, I call Professor Sanjeev Sinha.
I think it was a very good case, and I would like to congratulate the team. And when we admitted this patient, so initially you have seen that we have got bugged up in different point of view, but ultimately we have done the pus aspiration, then we have sent it for gene export, and we found that there is a replacement tuberculosis, and we treated this patient successfully. So, and we have done you have seen the baseline PET scan and CT and MRI that has been compared with the 18 months imaging, and it is clearly showing there is a clear-cut improvement, and there was, at the end of the treatment, the disease is completely resolved. So with this, we'll end the session here. If somebody have question or comments, so welcome.
I have got one request to the medicine department. Recently, that before the blood culture, blood test, in the routine blood work, they sent for is now in this time. And every TB patient for a responsible patient, this is overloading our college work. And then in neurology, we are saying everybody is a paradigmatic student. And in 400 cases, we analyze only 3 people. So you can see how the your clinicians are working. We don't have the numerical profile for neurology, but they send it to Bangalore and they don't get the person. That's all. Our oncology case is waiting for 3 weeks, but our EO cases are not. You can want to get the person here to do the request to the storm around. So that's why we have 80 pets scanners. It is already over. We do 50 pets a day. So that we will find 30 pets a day. We do 50 pets a day. So which category?
Sir, the point raised by Professor Bal sir is very well taken. We should use our resources more judiciously, be it the high-end investigation, be it the ICU bed and other things. So I think this is all related to the quality improvement thing, and as an institution, we all are party to this. But all I can assure you that from Medicine Unit 3, we never sent a patient for PET scan before getting preliminary investigation. Thank you very much.
Dr. Bal have raised a good point, but this patient needed PET scan. Nobody can deny. So what we are discussing today for this patient, for your point, will be careful. Okay. Thank you.
Almost privately